Next, I'll be speaking on the complex retinal procedure. So there are no financial disclosures relevant to this presentation. These are my acknowledgements. These my colleagues who have helped me in the preparation of this presentation, and some of the videos are also theirs. So talking a bit about digitalization in ophthalmology, we remember the time when the digital angiography came in. Purists scoffed at digital photography, but then we know that as resolution improved and hardware and software advanced, the digital completely took over. So when we are talking of the heads-up microscope, the ARTEVO 800, is this a new era or is it just a new toy? Some of the major advantages which we find with the heads-up system in the Lumira microscope is the surgeon comfort. You can sit upright. It's much easier on the neck and the back, especially for the older surgeons like me. There's high magnification, good depth of focus despite high magnification, excellent resolution at high magnification, especially at the posterior pole, where one finds one can do ILM even without staining. All observers can have the surgeon's view. So it's a great thing for teaching and for supervising fellows as well. The low light exposure for patients, there's less chance of light toxicity, ability to change color values of light. The blue light is good for high myopes, albinotic fundus, green for detecting subtle vascular proliferations, and in yellow you get less reflection under air when you do a fluid air exchange. One of the USPs of the ARTEVO system is the ability to switch from screen to microscope view without needing to change from the microscope head to camera. This is the inbuilt camera. Some surgeons just prefer the direct view. Even now in certain situations, we do switch to the binoculars. And even the question of digital software or hardware issues, in the rare occurrence that there is a breakdown, you have the reassurance of the backup of the binoculars. And in this system, the lag is reduced to an imperceptible level. Some of the disadvantages are OR logistics. The cataract surgeons sit temporal while doing combined surgeries. We sit at the head of the patient, so that sometimes can create some logistics issues. Assistant sometimes has to turn the neck to see the screen. You need more space. The placing of the vitrectomy machine, anesthesia machine, and the microscope have to be carefully planned. And we need to keep the screen close, about 1.5 to 2 meters at the most from the surgeon. Sometimes during the surgery, especially we get intraocular structures or reflective instruments can cause more glare. Working in the periphery sometimes poses challenges. And the dynamic range of a digital system still cannot match the human eye. So you have to vary the illumination much more while you are operating. The intensity of the endoillumination, the sensitivity of the camera or the software system, and is need a trained person at hand to do this while you concentrate on the surgery. So this is the setup we have for the heads-up surgery with the ARTEVO system. The future definitely is digital. We know this from digital imaging, phacoemulsification, advances in refractive surgery, that technology ultimately refines as systems will be refined and costs come down. Change is the only constant, and we can't stop the march of technology. Coming on now to the complex retinal procedures. So in the retinal posterior segment space, proliferative diabetic retinopathy, complex retinal detachments, trauma, and massive subretinal bleeds are some of the rather complex situations which we can encounter in our practice. And bimanual surgery is often helpful in this. As this little video shows, bimanually you can do something much more easily than you're trying to tie the shoelaces with one hand. So wide-angle systems give us a good view to the periphery, and smaller gauge instruments enable us to work closer to the retina. Both these, along with the self-retaining endoillumination devices, give us ideal conditions for bimanual microincision vitreous surgery. Coming on to PVR, major components of PVR are fixed retinal folds, equatorial circumferential contraction, anterior loop traction, and subretinal bands. And we'll see that in some of the subsequent videos. This is a PVR case, and you see that there's a tight contract fold at the posterior pole, and the retina is relatively stiff and immobile. And this thick membrane is being now gradually eased off the posterior pole and brought anterior. And now this membrane is brought up to the equator, up to the vitreous base, which is as far as it will go. Here we see again another fixed fold here, which is being relieved. And once this is relieved, the retina in that area also becomes much more mobile. Having tackled the posterior traction, now you see that there is an anterior loop here, and we are trying to relieve that so that the retina settles well, and we especially don't get any recurrences in the late stage, especially after silicone oil removal. Here we see with a very anterior pathology, we can work under microscope light with one or two instruments, and with the forceps and scissors, or even two forceps and a stretching maneuver, that traction there in the anterior space is relieved, and then the scissors removes that tissue. Having done that, the anterior retina also becomes much more mobile. And once the entire retina is made mobile and the anterior loop is also relieved, we go ahead with the fluid air exchange. So here's the retinotomy there and the fluid air exchange. The retina settles, and then the silicone oil will be injected. This is another case where the retina was held taut by extensive subretinal bands. And again, we see how bimanually it can be elegantly and efficiently removed. We see how this hand-on-hand maneuver with the two forceps, we are removing this extensive subretinal band. This is one of the largest I think I have ever removed in a PVR situation. And this is the entire band is sort of folded up. And even then the nasal side was still stiff, and there was still more in the subretinal space. Now we see this thick subretinal band being removed from the subretinal space there nasally. Once that is done, the retina becomes much more mobile and can settle it and put silicone oil. Moving on now to diabetic retinopathy. Proliferative diabetic retinopathy again can be very challenging. Here we see there is fibrovascular tissue and subhyaloid hemorrhage, but there's no elevation of the posterior hyaloid at all. So even here trying in the periphery, we could not get a plane to start dissection. So we made this.
We are not able to see the video. Video is not playing.
This one or even the previous ones?
The previous was playing. Now the PDR is not playing. Previous was excellent surgery.
I am able to see it. Is no one able to see that?
Can Dr. Reddy or anybody from Zeiss can see it?
Yes, the video is not visible.
You have a slide saying PDR creating plane when posterior highlight totally adherent,
Yeah.
and we are not able to see the video playing. Link is there. Link Dahya VTS VOB.
I think that link needs to be clicked and then a video player will open.
Okay. Maybe I'll do the other videos first and then.
Okay.
Yes, surely, not a
Do
problem.
that. You can do that. But the previous surgery was very good. Now this is plain.
So this was another case of PDR where there was the fibrovascular tissue. Now the last part is being removed. This was a young diabetic, an army officer. And after that, we still found the retina in the temporal side looking stiff, and we found there was some subretinal hemorrhage. Now, subretinal hemorrhage we do encounter in diabetics, but usually it's mild. But we had this, since the retina was stiff, we now put in a PFCL bubble to protect the macula and then decided to remove that subretinal hemorrhage. And to our surprise, there was this huge clot. And then finally, we removed this clot bimanually. It was tending to spring back. So again, with the same hand-on-hand maneuver as we had used for the subretinal band, we removed this rather large subretinal clot. And once that was removed, the retina looked a lot better and more mobile. And then with the usual fluid air exchange, and then we used gas in this case. This was a case of subretinal hemorrhage that colleague Dr. Cyrus presented. This is again massive subretinal hemorrhage, and this sort of a hemorrhage you cannot remove through just making a small retinotomy. So we had to make a large peripheral retinotomy and reflect the retina over. Here you see the retinotomy being extended. This was a trauma case. There was a vitreous hemorrhage and subretinal hemorrhage. Here you can see a lot of the hemorrhage in the subretinal space. Sometimes it is subretinal, sometimes even it can be sub-RPE. And then you have to really decide how aggressively you need to go after that and what part of the hemorrhage can be left alone to avoid removing huge areas of retinal pigment epithelium. Thank you for your that the plane in the periphery, we cannot find this. And so we make the incision over the area of the subhyaloid hemorrhage over the macula and between the macula and the disc. And then we find from there we can extend this hyaloid separation over the disc and then see where this separation happens easily. Here it's in the lower nasal quadrant. We can find that we can extend this peripherally, the separation, and then kind of almost like a rhexis, turn it around circumferentially, and we find this gradually this hyaloid is separating from the retina. So we separate as much as possible, which can happen with just a controlled and gentle traction so that it separates, but without creating a retinal break. And if there's any area which is more adherent, then we would leave that alone for dissection later on. So now all this fibrovascular tissue is removed and the case is closed with a gas exchange. Thank you.